Okay, next up in our series on prescription drugs, it should be familiar to you guys going back to your PCP pharmacology classes. Today we're going to talk about cardiac medications. Alright, so now that we've just survived the flashback of studying the von Willems classifications, let's take a breath and talk through some of these. This is going to be really short, as a lot of the treatment around these is arrhythmia management and bicarb, two things that are pretty far out of the PCP scope. So prescription cardiac meds are typically used to treat arrhythmias, normally the fast ones, but they can also be used to treat some hypertension. They're all designed to slow the heart down, and they all work by blocking something, whether that's a receptor site in the synapse like beta blockers, or an ion channel in a myocyte like the rest of the von Willems drugs. So in an overdose of these meds, the one thing that they have in common is that your patient will probably be hypotensive. They'll likely, but not always, be bradycardic. So our von Willems classes of cardiac medications are type 1 sodium channel blockers, type 2 beta blockers, type 3 potassium channel blockers, and type 4 calcium channel blockers. So let's take a deep breath and have a look at some of these. We'll start nice and easy, beta blockers. Typically these are going to be selective beta blockers like metoprolol, and they work by blocking epi or norepi in the sympathetic system. Normally the beta receptors increase the amount of cyclic AMP inside cells, which increases calcium intake and causes the muscle cells involved to contract harder and faster. So like I mentioned before, they're typically selective to B1 receptors, so that's only going to affect the heart rate. But they can also be involved in B2 and B3 receptors, lungs, and thermogenesis of fat cells. So when someone ODs on beta blockers, they're going to be profoundly bradycardic, and that's likely going to cause some accompanying hypotension. The trick with these patients is that the normal bradycardic treatment of an epi infusion won't work, since all the epi receptors are blocked. Instead, you'll often see these patients get electrically paced or given glucagon IV. So glucagon stimulates that cyclic AMP inside the cells, so basically it bypasses the beta receptors altogether. Just to clarify, IV glucagon is currently not in the PCP scope, so this is something you're going to need an ACP or a physician to do. Next up is calcium channel blockers. We're talking about drugs like amlodipine or diltiazem, another drug commonly used in hypertension management, but you may also see them in patients who have a history of AFib. These drugs work just like they sound. They stop calcium channels from working, which decrease the strength and frequency of contractions inside muscle cells. Some of these drugs are cardiac cell specific, called non-dihydropyridines, and some are not, focusing more on those peripheral smooth muscles, or hydropyridines. When looking at calcium channel blocker overdoses, the most common arrhythmia will be sinus bradycardia or some type of an AV block. Also look for long QT intervals and new bundle branch blocks. On top of that, hypotension, signs of end organ perfusion, so ARDS, seizure, decreased urine output, and hyperglycemia are all common. Treatment, besides symptom management, is going to have two parts. One, stimulate any calcium channels that aren't blocked with more calcium, usually by giving calcium chloride or calcium gluconate, and two, insulin therapy. Calcium channel blockers decrease insulin production, so cells don't get the sugar they need, which can lead to some anaerobic metabolism and metabolic acidosis. Next is our sodium channel blockers. These can be subcategorized in types A through C, with type 1A being having a weak effect on the sodium channels and 1C a strong effect. These drugs are used most commonly for antiarrhythmics, but they are also a powerful anesthetic, and you'll commonly see them used in hospitals for those reasons. Some are commonly used for their anti-seizure properties as well. Blocking sodium channels slows down transmission through nerve cells, so it increases that seizure threshold. An overdose on these medications will cause bradycardias and hypotension like you would expect from any other cardiac medication, but sodium channel medications can also cause that prolonged QT interval and a widening of the QRS complex, as well as some anticholinergic effects. These ECG changes are very similar to what we've seen in cocaine overdoses, as well as in TCA and aspirin overdoses. Treatment here is going to be supportive with sodium bicarbonate, which works for two reasons. Any sodium there is going to activate the sodium channels that aren't blocked, and the alkalotic effects will help the metabolism and excretion through the kidneys. Typical dose is 1 to 2 milliequivalents per kilogram to get that QRS complex back down to less than 100, and then afterwards you'll see a maintenance infusion.